Can you see my screen?
I can see it.
Okay. We'll start in a second. Good afternoon, everyone. Welcome to the Zoom academic meeting of the Department of Pediatric Surgery. Today, Dr. Karen Milford is going to give us a talk on an approach to ureteric abnormalities. Dr. Milford is a pediatric surgeon and urologist at Nelson Mandela Children's Hospital in Johannesburg. Sorry, I'm not sure what has happened to Karen's photo. It was here, but the computer seems to have eaten it up. I'm sorry about that. And I think she is probably the only qualified pediatric urologist in the country, if I'm correct. She did her undergraduate training in the University of Pretoria. She did her pediatric surgical training at Red Cross Children's Hospital in Cape Town. And subsequently, she did a fellowship in pediatric urology at the Hospital for Sick Children, Toronto, Canada, for over 2.5 years. Currently, she is an honorary lecturer in the Department of Pediatric Surgery at the University of Witwatersrand and consultant at the Nelson Mandela Children's Hospital. Dr. Milford is going to talk about ureteric abnormalities, and without much introduction, I will request her to start her presentation. So Karen, you can share your screen and start your presentation. Thank you. Karen, you can share your screen and start your presentation, please.
Sorry, it keeps saying share screen has failed. I'm going to try again. All right, can you guys see that?
Yeah, we can see it. You can carry on. Thank you.
I'll briefly put my video on just to say hi. Yeah, so thank you for that nice introduction. I think just as a qualification, I think we do have many very experienced pediatric urologists in the country, and I certainly have trained with some of them. I think maybe I'm just the only one at the moment who did a fellowship overseas, although to be honest, we're not really sure. So I'm just going to do a talk today on an approach to ureteric abnormalities, because it's actually something that is not super common. You know, we read about it a lot, but we perhaps don't actually see it in our practices as much as what, you know, our teaching would train us to expect. And I found even when I was in Toronto, there's a lot of controversy about how to manage ureteric problems, perhaps because there really are a lot of options and we're not always sure on what the best one is. So in this talk, I'm just going to touch on the presentation and investigation of patients with ureteric abnormalities. We'll briefly look at the differential diagnosis. And then I'm going to look at the management options, chiefly of duplex systems and mega ureters. I'll just briefly touch on urethral cells, but in the end, I decided not to dedicate too many slides to these because I think urethral cells in themselves are quite complex, and we could talk for quite a long time just about the management of these. So moving on to presentation, I think the presentation of these anomalies is really dependent on your clinical setting. So, you know, in Toronto, I think the vast majority of these were picked up antenatally. So these infants will have antenatal hydronephrosis on their ultrasounds. Some of them may be picked up incidentally in patients undergoing imaging for other reasons, such as suspected appendicitis or, you know, yeah, non-specific abdominal pain. And then I think a large number of our patients present with symptoms. So UTI or infection of the obstructed system or the reflexing system is common. Some of them will present with pain, particularly the older children. And I think those patients with primary megaureters sometimes get stones, and they can present with pain. Urinary incontinence is an issue, particularly in girls with ectopic ureters implanting beyond the sphincter complexes. And then we also have the subgroup of patients who present with bladder outlet obstruction due to obstructed urethra seal, due to prolapsed urethra seal, which is something I think pediatric surgeons and urologists should know about to know how to manage urgently. So just on the workup, as always, we start with a history and exam. So yeah, you want quite a clear history of urinary tract infections. And I think it's always good for your practice to know what the definition of a UTI is, because patients will be investigated or treated for UTIs without definitive evidence or without really meeting the criteria. They may have underlying pathology, even if they didn't have a true UTI. But it's important when you're deciding on your management going forward to know whether or not your patient is having true UTIs. A history of trauma, particularly in older children, is important to know, particularly whether or not there's been any perennial or kind of like bicycle or sort of what I call tree branch trauma, so like falling onto something that may have caused a urethral stricture. Always good to inquire about antenatal scans. They may have been a history of mild or moderate hydronephrosis that maybe disappeared with time, but it's also useful to know if the antenatal scans were reported as being completely normal. You're obviously going to look for palpable masses. The genitalia are important to inspect, particularly in girls where you're kind of looking for evidence of a prolapsed urethra seal. And then with all urology patients, always, it's important to inspect the lower back and really satisfy yourself that there is no evidence of an occult spinal abnormality. So when you're looking at a patient who's either, as always, presented with a UTI or who has a history of antenatal hydronephrosis, you're going to start with ultrasound because it's the least invasive and the easiest to start with. And the first thing you want to know is about the kidney morphology. So specifically, what how much hydronephrosis there is, if there is hydronephrosis, and also whether or not the parenchyma is affected. So is there parenchymal thinning? Is there evidence of parenchymal scarring? And then also size of the kidney. So is there evidence of dysplasia or of a small kidney? Laterality is important, and it's also very important to know if you're dealing with bilateral or unilateral disease. We'll get into that at the moment. And then an actual estimation of the size of the ureter is quite important because the ureter really needs to be more than 0.7 millimeters in diameter to be truly classified as a megaureter. And all of these things are also important serially. So you want to know if your hydronephrosis is getting better or worse, as the same goes for your hydroureter. So if you're, some of these children may or may not, and we'll just kind of talk briefly about like how you're going to go on to investigate children when we talk about risk stratification. But in children who go on to have a VCUG, which obviously involves catheterization, ionizing radiation, and can also be, in my experience, a bit of a difficult investigation to do in older children. So you really need to be clear on your indications for doing it. So the first thing is that you're really going to want to do a VCUG, I think, in children with bilateral hydronephrosis or hydroureter, children with, I would say, with recurrent infections, and children with renal dysfunction, because as always, what you're trying to do is exclude valves, which can present with unilateral hydroureter and can often have actually a very subtle presentation in terms of upper tract findings, but really shouldn't be missed. The bladder is also important to look at. So you want to look at evidence of urethra cells. And then I think always get an idea of whether or not there's trabeculation, if there's diverticularly, and other evidence of what I would think would be a neurogenic bladder. And then you obviously want to know if there's reflux. So functional scans, once again, it's as you're moving down your diagnostic pathway. And really, when you are moving on to asking for a functional scan, once again, you're asking for very specific questions. So you want to know the differential function of all the renal units. So you don't just want to know the differential function, the differential between left and right. If you're dealing with a duplex system and you are going to subject your patient to nuclear imaging, then the technologist needs to be able to tell you what the differential function is in the upper and lower moieties of duplex systems as well. And the reason for that we'll get into in a minute. And then if you're going to do a diuretic renogram at the same time, because you're essentially trying to look for evidence of obstruction, either at the level of the UPJ, so the uretero-pelvic junction, or at the level of the bladder, so which would indicate more uretero-vesical junction obstruction. And then just briefly to mention that you will seek other imaging if you're concerned about a spinal lesion, and also in patients where you have any reason to suspect that they will have renal dysfunction. So that's actually the vast majority of the patients, but you don't want to miss a patient who is already having a sort of renal disease as a result of their their ureteric abnormality. So when we're thinking about a hydroureter, in the context with or without hydronephrosis, although most of them do, your differential is sort of your megaureter, and this can be subclassified into megaureters that reflux. So megaureter really just refers to an enlarged, dilated hydroureter, basically. And as I said before, technically, it should be more than 0.7 millimeters, 0.7 centimeters distally. So these can be due to reflux purely, so dilating reflux. They can be due to a primary obstructed megaureter, and I'll discuss that in a bit. They can be obstructed but reflux at the same time. And then you also get these subcategories of ones that are neither refluxing nor obstructed. And often these children have more of a systemic illness that might be inducing polyuria, such as diabetes insipidus. The duplex systems are something to think about. Your radiologist really needs to know how to look for a duplex system in the upper tracts. Urethra cells, you will see hopefully on ultrasound. It can be difficult. And then, as I mentioned before, I'm not going to talk too much about secondary megaureters, but whenever you are dealing with a child with hydronephrosis and hydroureter, it is always really important to make sure that this isn't secondary to lower urinary tract pathology, such as valves, atresias, stone disease, or a neurogenic bladder. So management goals, as always, in urology are to preserve renal function, so to keep the kidneys healthy, to minimize infections, and then to achieve continence. And when I think about the management strategy for a hydroureter, the first thing I try to do is decide how high risk my patient is. So are they at risk in terms of losing functional renal units? Are they at risk of developing an infection? And are they at risk of kind of deteriorating? In many of these patients, it is possible to be conservative. Urological surgery can always be as simple as we think it should be. It tends to be highly complex, I think, and where possible, we should be conservative and not do more harm. And then the right operation at the right time in the right patient, which I think can be quite difficult to decide on. So when you're dealing with a hydroureter, you need to kind of stratify the risk, and there are various ways of doing this. There's image-based risk stratification, which is upper tract dilatation scoring, which is really just using ultrasound. And as I say, in urology, it's almost always divided into thirds. So you've got the low risk patients where you know you really don't need to do anything. And then you've got high risk patients where you know that there's probably a problem and that you probably are going to have to do something. And then this medium risk group, which is somewhere in the middle. So on the left of my screen here, we're just looking at ultrasound-based criteria, which look at the APD, which is a very objective way to look at hydronephrosis, and has the benefit of being reproducible, where ultrasounds can often be quite variable. There's another grading system, so the Sfu grading system, which looks more at clubbing of the calyces and sort of a global picture. I haven't actually included a picture of it in this presentation, but I think it's a little, perhaps gives you a bit more information, but is much more subjective. So isn't always the best system to use for people who are not very familiar with pediatric renal ultrasound. So obviously the worse your hydronephrosis is, so the wider your APD is, the more parenchymal damage or abnormal parenchyma you have, and the more abnormal your ureter is, the higher risk you would consider your patient. But I think the clinical picture is really, really important as well. So children where there's a history of infection, and particularly when there's a history of recurrent UTIs, I would always consider high risk and consider intervening. Children with a history of bladder outlet obstruction, so if their urethral cell has occluded their bladder neck and they've had an episode of being unable to void, I would consider that an indication to intervene. And then if there's evidence of renal dysfunction, so your parenchyma is getting thinner on your functional studies, you're seeing a wide differential, or you're seeing deterioration in renal function on your lab results, then I think you need to consider intervening. But we'll talk about intervention in specific settings in a minute. So I'm just going to briefly touch on antibiotic prophylaxis. I think, so there's quite a lot written about antibiotic prophylaxis for various upper tract abnormalities and looking at the potential for them to decrease infections. And I think the studies most of us are mostly familiar with are the studies that kind of looked at continuous antibiotic prophylaxis in children with reflux. So many of these hydroureter patients do not have reflux, they've got an obstructed system. And I think it's kind of institution dependent, to be honest, that the institutional culture often determines how often antibiotic prophylaxis is used. But there is evidence that it shows it decreases the incidence of UTI in obstructed patients who are high risk. 1/3 of primary obstructive megaurethra patients require a single hospitalization for a UTI, and that includes those who've had some kind of decompressive procedure. And we do think that the antibiotic prophylaxis decreases the chance of that. And then, there are a couple of guidelines and consensus documents that do recommend prophylaxis for the first 6 to 12 months of life, and then stopping it after that and seeing how things are going. So just firstly, let's just talk about who we probably don't need to intervene on. And firstly, those are the children with incidental asymptomatic duplex systems. So those where the duplex system was picked up antenatally or picked up incidentally with an ultrasound for another reason. And those patients, you can have duplex systems that have absolutely no hydronephrosis at all, and you wouldn't intervene there. Asymptomatic urethral cells are sometimes identified. They should be intravesical. They shouldn't be causing any obstruction. The children shouldn't be getting any infections. Those can probably be left alone. And then the primary obstructed megaureter, the vast majority actually resolve. So like about 80 to 85% actually resolve with time. So those children who've not had any infections, who've got a ureter less than 1 centimeter wide, have got a normal looking kidney, and their split renal function is not concerning, can also be observed. Who need surgery? Incontinent girls do need to be addressed. If the ectopic ureter is implanting outside of the sphincter complex, you won't be able to resolve the continence with anything other than surgery. We can talk about surgical operations in a minute. If there's progressive dilatation of either pole, but probably in particular the upper pole, and then obviously in all three of these groups, we say it over and over again, but children who are having infections need to be addressed. Urethra cells, like we said, those who are prolapsing, once again, need to be addressed. Where we're seeing progressive dilatation, even if the urethra cell itself is quite small, but we're seeing progressive upper tract dilatation, intervention should be considered. Once again, if there's deteriorating renal function, and then if the urethra cells are bilateral. Primary obstructive megaureters, I actually discuss this again in more detail later, so I'll get into it there. So let's look briefly at duplex systems. And before we go into kind of the management options, I'm going to just do like a quick overview of some things that are sort of important to understand when you're thinking about duplex systems. I'll put my laser pointer on. So the Weigott-Mayer rule is important to remember because it determines so much of the pathology and it guides so much of the management. And that is that the upper pole obstructs, and the upper pole is the ectopic ureter. The lower pole tends to reflux, and that ureteric orifice is more orthotopic. Sorry, I just want to get rid of this pointer. Just go back. So this kind of guides our how people present. So asymptomatic, as I said before, they can have a complete or an incomplete duplicated system. They might be going into a single ureter, and these are often an incidental pickup. But when you have a known duplex system who is presenting with UTIs, it can be difficult to know what the source of the UTI is because you have an obstructed upper pole, and we know that any obstruction within the urinary tract can predispose to sepsis due to stasis. But then you also have a refluxing lower pole, and we know that reflux also predisposes to infections. Sometimes the ectopic ureter can implant in the seminal vesicles in boys, and these boys can present with orchitis, which is why whenever I have a patient who presents with an episode of orchitis, even if we haven't successfully grown an organism, I will proceed to a normal UTI workup, and I'll start with an ultrasound for them and proceed from there. And then, as we know, you can have upper poles, you can have upper moieties that are not obstructed and not dilated, but an ectopic ureter that implants below the sphincter complex and can present with incontinence later in life. These girls are often actually picked up quite late because it's quite a, around the age that they go out of, it can be quite a difficult history to get. And some of them also do have an element of voiding dysfunction. So often those things are addressed first, so the constipation and, generally these girls often present sort of without a UTI and without any kind of red flags, and so will be managed as children with voiding dysfunction first, and an ultrasound is not necessarily part of their workup if there are no red flags. So it can take a while for their duplex system to be identified, but once it is, then you can offer them some options. So like I said, when you do have a problem, usually an infection in a duplex system, you need to work out where it is. So the ultrasound starts off by telling you which moiety is dilated. Is it the upper moiety, the lower moiety, or both? The VCUG, we'll look at some pictures now, tells you if there's reflux, and both the ultrasound and the VCUG can help you identify your urethra seal. And then the functional scans, so a DMSA or a MAG3 are important in that you want to know exactly how much function each moiety contributes to the whole. And that is because if you've got an upper moiety which is contributing like less than 10% of function, it affects what kind of operation you may choose to do for your patient. Sometimes it doesn't. But if you've got a renal, so an upper moiety, that has more than 20% of the global function, you would really want to try and preserve those renal units. Less than 10%, I think many urologists would be kind of comfortable with sacrificing those renal units. And then we all kind of have difficulty with the units that are in the moieties that are contributing between 10 and 20%, although I think most of us would probably try to preserve them. MRUs are, I think, actually, to be honest, less useful than what we would like them to be, but they are kind of useful in determining the course of an ectopic ureter, especially in patients who don't have dilatation or hydroureter, and you are really suspecting in girls, incontinent girls, an ectopic ureter. Sometimes the ultrasound imaging can be quite, not really super helpful. And then the MRU can give you an idea of whether or not you've got bilateral duplex systems or unilateral, and what the course of those ureters is. I've just included some images here so this is just kind of a duplex system to give you an idea. This is probably a normal functioning lower pole, and this is probably an obstructed upper pole. You would also, this is just a static single image, but on your ultrasound, you're also going to get an idea of whether or not that upper pole has got good parenchyma or not, or if it's just kind of, a cystic non-functional unit. And here we have a VCUG, which is showing reflux. I have to say, like, interestingly enough for me, like the Wyckoff Mayer rule, it tells us that it is meant to be the lower pole that refluxes, but we'll talk briefly about urethra cells in a second. But, it isn't always, sometimes both poles reflux. And that is kind of, I think, useful to know before you actually proceed to anything. And this is really, so when you are going to manage these patients surgically, you really need to have a clear idea in your head whether or not you're trying to address the obstruction, the reflux, or both, particularly when you consider that whatever you do is not necessarily going to solve the problem. So you can do, whatever procedure it is, they might still come back with a UTI, and then you need to ask why that is. So a common She3 implant, I think, is probably the most conventional surgical procedure. And the reason it's favorable is that it addresses both issues in one go. So it's pretty conventional. It addresses the reflux in the lower pole, and it addresses the obstruction in the upper pole. I'll have to say that as much as we teach this as like, the kind of gold standard of the procedure, it's not actually a very easy procedure. And I think not a procedure that people who don't do a lot of urology and particularly upper tract work are comfortable with. So, we talk about it often, but, the occasion to actually do an operation like this doesn't arise very often. And so I think a lot of people are not, super comfortable actually doing it. If you've got a very dilated ureter, you need to consider tapering or even excising part of the ureter. We'll talk about more about that when we discuss the primary obstructed megaureters. And then also, I think most, more and more urologists are quite reluctant to do these sorts of reimplants in very small babies. So those are babies, I would say, less than even 9 months to a year old, because you do risk damaging the bladder and causing bladder dysfunction later on. So urethral cell puncture is a pretty simple procedure, particularly for children who have a big urethral cell in an obstructed system that may or may not be prolapsing, but is also occupying a whole lot of bladder volume. The problem with, so urethral cell puncture is very satisfying in that your obstructed system gets relieved nice and quickly. There are case reports of like the urethral cells like sort of resealing over and recurrent obstruction, but for the most part, I think you generally often get like relief of your obstruction and time for the baby to grow. The problem with urethral cell puncture is that it really aggravates your reflux. And when you've got a patient with a duplex system, I can tell you from personal experience is that there is nothing more frustrating than, or like kind of worrying than knowing you've got a patient with duplex systems where you punctured the urethral cell and now they're back with a repeat UTI. You ultrasound them and you see the upper pole is a little bit decompressed, but at this point, if you do a VCUG, you're going to see massive reflux now into that upper pole. And sometimes you even see contralateral reflux and reflux into the lower pole. And then you kind of really stuck. In general, we treat the UTI and maybe put them on prophylaxis and hope that it gets better. But some of your, I'm not going to talk much about reflux today. After you've punctured a urethral cell, you can't really deflux that ureter. If they come back with repeat infections, you don't know, which ureter of the 3 or 4 ureters that the patient has is causing the problem. And in these patients, if they have recurrent UTIs, you would be obliged to do a common She3 implant. So Ureter Ureterostomy is actually an operation that is quite nice. So what this does is it resolves your upper moiety obstruction without without you needing to do a reimplant at the level of the bladder. Without, well, we'll talk about nephroureterectomy in a minute, but you don't need to resect any part of the kidney. It preserves the upper pole function, and it's generally not actually a very, I have to say, difficult operation. We would usually recommend doing a cystoscopy before and putting a double J stent into the orthotopic ureteric orifice so that you've got a stent in your lower pole ureter so that you can feel it. You can do a little Gibson incision, which can be ultrasound based. You know, if you've got a dilated ureter, you can identify the ureter sort of here at the edge of the bladder. And really all you do is anastomose this upper pole ureter into the lower pole ureter. This can be a challenging anastomosis when there's a huge size discrepancy. So these upper pole ureters can really be very dilated, which can make this anastomosis difficult. And I think it can also be a bit concerning because you don't want to, so what you're doing is taking generally this lower pole ureter, maybe it has a bit of reflux, but on the whole is quite a normal, healthy ureter. And you're now going to open it and plug an abnormal ureter onto it. And there is worry for anyone, I think, that you're going to damage this lower pole ureter and then knock off the whole kidney. But the advantages are that it does avoid difficult bladder surgery and can be done in quite small babies. And then once again, this doesn't sort out your lower pole reflux, you know, if that is a concern for you. I would say that if you're still getting recurrent, you know, as always, likelihood of UTI is there, but if you're getting recurrent UTIs and you've got proven ongoing reflux into the lower pole after this procedure, I think you would once again be obliged to do a reimplant. Apopol Uretronifectomy. So this is really only indicated in children where the upper pole is causing problems, but with very little with very little benefit. So this is a pole that is perhaps very dilated. It might even be causing compression of the lower pole and mass effect on the lower pole. Once again, recurrent UTIs, and also even girls who are perhaps incontinent from their ectopic ureter. So this gives you definitive removal of the problematic pole, but this is not a super easy operation. It can be done, I think most people, a lot of urologists would elect to do this robotically or even laparoscopically now, but it can still be quite difficult. And injuries to the vascular pedicle of the lower pole during this operation are actually quite well described. So you actually need to be pretty comfortable with the surgery. So, you know, a confident, I think, renal surgeon, know your anatomy really, really well. And then it's important that you really need to resect all of the upper pole parenchyma, because if you don't, the remaining parenchyma will continue to secrete a bit of urine, and you can get urinomas and other irritating problems. So I'm going to talk about, because I was in Toronto and this procedure was described there, and there's a lot of interest in it, is the concept of ureteric clipping. So it's very, very controversial. I'll show you a screen grab of the article heading, and if anybody's interested, I can send you the article on it as well. But it's kind of controversial because that sort of goes against everything we're taught in urology, which is that the urine must leave the body. But its advantages are that it's very easy. It seems to be particularly useful in girls with dribbling. The one, I would say, absolute contraindication to it is infected systems. So I would actually not attempt this procedure in a patient who has ever had an infection in the upper pole system, because the complications that they described in those patients were fairly significant. And what I will say as well is that the group doesn't actually, you know, they haven't written up their long-term results. These are fairly short to medium-term results. And so we're not really sure actually, like 10, 20 years down the line, what is happening with these patients. But just to kind of run through, maybe let me see if I can go back. So basically in Toronto, this is done as usually it's done as a laparoscopic procedure, but can be done open as well. And what they do is they first do a cystoscopy, and once again, put a stent. You can just see sorry, let me put my laser back on. You can just see the green of the stent here in the lower pole orthotopic ureter. And very simply, what they actually do is just pop a couple of Liger clips onto the ectopic ureter. So yeah, it's 1 or 2 Liger clips, and then they divide it. So this procedure, I have to say, is very quick and uncomplicated. Can also be done through a very small kind of lower quadrant incision. So the reason they felt confident attempting this procedure is that firstly, the transplant literature just tells us it's safe. So there's a subgroup of transplant patients where for one reason or the other, the native ureter had to be sacrificed. And when the transplant kidney was put in. So I think some of these are patients who had kind of ureter to ureter anastomoses because the donor ureter was perhaps not long enough or had been too devascularized to go onto to the bladder. And in transplant, rather than doing a complete nephroureterectomy, a lot of these ureters are just tied off. And over time, the kidney simply stops producing urine and there weren't many complications. So this is obviously when you're clipping that upper pole ureter, you're essentially defunctioning the upper pole because it is obviously not able to evacuate its urine anymore. And so to my mind, this is an alternative therapy to an upper pole nephroureterectomy. If you have an upper pole that is still providing a lot of function, so on your functional scan, it's got function of more than, I would say 10, 15%, then this is not, I don't think, an appropriate operation for those patients. When they did their study, they divided their patients essentially into 4 groups. So there was the duplex with the ectopic ureter. These were the girls who had incontinence, a duplex with a large urethra cell, and then what they called other duplex and single system kidneys. So they did their operation. They noted that the incontinence resolved itself. They continue to monitor hydronephrosis, and I have to say that in all groups, the APD of the upper pole does actually increase. But when they did their statistical analysis, it was only significant in the girls with incontinence. So even though there was still some persistent hydronephrosis and perhaps even increased hydronephrosis, it wasn't statistically significant. The urethra cells, I think, in particular, were very rewarding. So the size of the urethra cells was significantly decreased after the ureteric clipping. I saw some of these patients long term, and we can perhaps, if anybody's got questions about this procedure afterwards, we can talk about it. Moving on to the primary obstructed megaureter, which I think can be like a management challenge for many people. So once again, we're going to confirm the diagnosis and stratify the risk. And you really want to be have very specific questions for yourself and for your radiologists when you're doing this process, because it really, really directs therapy. So sorry that it's kind of gone hazy on the side here, but the first thing is you really want to know about your renal parenchymal quality. Because once again, I said a large majority of these actually resolve spontaneously. So you really need to use your investigations and kind of a clinical history to decide where you're going to intervene. So parenchymal thinning is not a great sign, and progressive hydronephrosis and worsening kind of parenchymal thinning is an indication to intervene. The ureteric diameter, so this is a patient with a very, very tortuous ureter. I think her diameter was kind of 1.5 centimeters at its maximum distally. The ureteric diameter on its own is not won't guide you particularly with regards to surgery, because even very wide ureters can resolve on their own, but you kind of want to get serial measurements. And if you've got a ureter that's increasing in size, you might want to think about intervening there. Because it's a mega ureter, you really do want to look for reflux. You want to confirm normal urethra. This is very important. You want to make sure that this is a primary megaureter and it's not a secondary megaureter due to valves or some other kind of lower urinary tract or bladder pathology like a spinal defect. And in the functional scan, once again, very specific questions. You want to know exactly how much is the difference between the two kidneys. And this is also important from a serial point of view. And then I would usually ask for a diuretic renogram at the same time and ask for the technologist to look at both the kidney itself and the ureter to see if they're empty. This is obviously a very extreme picture, but you do get children who have a UPJ obstruction. So they obstruct UPJ, we all know what that is, but who also have an element of hydroureter. And then the question for yourself then is, are you going to do a pyeloplasty or do you actually need to assess the, address the UVJ? And that's where a nuclear medicine unit that can kind of separate these two organs, the kidney and the ureter for you, and tell you at what level the obstruction is very useful. So spontaneous resolution is possible, and that's the thing, because often these children have a very dramatic and very sort of terrifying ultrasound, but even so, many of them get better. And the theory behind this is that the pathology is in the distal segment of the ureter, which remains a little bit adynamic, but is perhaps the last part of the urinary tract to mature. And so in infancy, sometimes, there is maturation here. So ureters that are less than 10 millimeters in diameter, the vast majority resolve. But even those that are more than 10 millimeters in diameter, a number of them will not resolve completely on ultrasound, but they will be asymptomatic. So they might not be having infections. And when you do your functional scan, you might see that there's good drainage and that there's good differential renal function. And on serial ultrasounds, that the hydronephrosis doesn't progress, or it even gets a little bit better. They might never have a completely normal ultrasound, but functionally things will be fine. And so even the very large ones, only about 1 in 5 will actually go on to need surgery. So who definitely needs surgery? As always, recurrent infection. So like I said, about 1/3 of these patients will definitely have a UTI in their life, even if you operate them. Children with progressive hydronephrosis on serial ultrasounds. And here's really a question is, how often should you ultrasound them? If it's an antenatally diagnosed hydronephrosis, you want to get an ultrasound, I would say, within the first 2 weeks of life. And then for me, if it's a significant hydroureter, so more than 0.7 millimeters in diameter, if there's some parenchymal thinning, but in the absence of a UTI, so you've still got an asymptomatic and healthy neonate, I would usually opt for a repeat ultrasound in 2 to 6 weeks, just depending on how I'm feeling. I think there are some other experienced urology people on this call who can maybe tell me how they go about it. And there are some kind of clear protocols that different institutions follow, but that would kind of be my strategy. Parenchymal thinning, like I said, particularly if there's progressive parenchymal thinning, I kind of start to be a little bit worried about, as I said, the ureters that are more than 10 millimeters, and I'd probably observe these more closely. And then I think this is where, the functional nuclear medicine studies are really useful. So if your affected side has a differential renal function of less than 40%, or some books would even say if the difference is more than 10%. So if you've got 45% and 55% on one side, but also if on serial functional imaging, you've got a deterioration of more than 5% over time, you should consider intervening. Obviously, this is over quite a long time because you generally aren't doing MAG3s every kind of 4 weeks. You're probably spacing them out by 3 to 6 months. And usually, I think if people are that worried, I'm not sure that they invariably wait that long to do serial MAG3s. And then you really, once again, have many surgical options, and these depend on the size of your patient. Are you dealing with a newborn? Are you dealing with an older child? The size of your ureter, whether or not there is currently infection, and really also what you're comfortable with. So for your children who present, with an acute problem, so for example, pyelonephritis, I think a nephrostomy tube is not a bad option. They're actually perhaps not that difficult to do if you've got interventional radiology at your center and you're not kind of comfortable with ureteric surgery, then the nephrostomy tube is obviously always a safe option for children who need urgent decompression, even those who are too sick to go to theatre. A cutaneous rhyostomy is something that I favor quite a lot in young babies. Stenting, not something I've ever done, but there are centers that do it. I'm not sure it's not an option for everyone. We'll talk briefly about the reflexing re-implants. And so these are really for decompression. So these are tied over a patient who has either had an infection or is perhaps too small for a definitive re-implant. So your definitive surgery would be your ureteric remodeling and a re-implant. And then Toronto used the side-to-side Uretrostomy as definitive surgery. Once again, controversial. So stenting, so this is, exactly what it sounds like, cystoscopy and placement of a double J stent through the ureteric orifice. It has been, like I said, done in some centers. I think it's really not as easy. So you have to really have very small stents available. And often that distal segment of the ureter and the UO, like anybody who knows, who's done a cystoscopy for some of these patients will know that that UO is often really, really tiny. And it's really difficult to get a stent in. The problem with these is that, you know, the stent needs to stay in for like a good kind of 6 to 12 months. Some of them will need recurrent stenting in that time. So it involves like several anesthetics and a fair amount of ionizing radiation because you're supposed to do it under fluoroscopy. Although half of these patients ultimately no longer need surgery, about a third actually have complications. So the stents migrate and fall out. Like I said, you've got repeated doses of ionizing radiation and anesthetics. Some of these patients do actually ultimately end up with loss of renal function. So deteriorating renal function on the MAG3s, and some of them actually ended up with nephrectomies. And then the other thing is that, you know, in those patients, so your kind of 30 to 40% who do require further surgery, you know, the stent really does inflame your ureter and make that surgery more challenging. This is probably not really an option that I would opt for in small babies. I think perhaps like an older child where you're just trying to temporize them, it's, you know, not a bad way to go, but probably not my preferred option for a neonate. So cutaneous urostomy, like I said here, I like this for small babies. I have to say, especially for pediatrics, so I think, you know, pediatric surgeons are often intimidated by the ureter, but for those of us who are kind of you know, very used to doing, for example, descending colostomies for patients with anorectal malformations, this operation is actually very, very similar. The main difference being that you're doing it through a Gibson incision and you're trying to stay extraperitoneally. But then, yeah, you can bring a little loop cutaneous urostomy. It's not a huge surgery. The babies recover very quickly after it. And it buys you lots of time. So if you've got a nice functional urostomy and a decompressed system, you can leave your baby until they're about a year old and then go and do your re-implant. Stomal stenosis is a well-described problem, and some of them need revision. Stomal prolapse, perhaps not so much a problem. The ureter might still not drain after this procedure. As you saw in that ultrasound that I showed you, the ureter can be really, really tortuous, and sometimes just opening it here is not enough because the ureter, in addition to being very dilated, is aperistaltic. And even though you've opened it, it might just kind of collapse on itself and not be able to empty it. This is also really not a particularly good option in patients with bilateral disease because you end up defunctioning the bladder, which is not ideal. So bringing out stomas bilaterally, you leave a fallow bladder, which then doesn't cycle. And can be problematic later on when you kind of want a slightly bigger bladder and also a functional bladder to do your reimplant in. So this procedure, I personally don't have experience with. The TRUR, which was described in Indiana, which is temporary reflexing urethral reimplant. And essentially, this is once again for babies who are either too small or too sick for a full tapered or remodeled reimplant. The idea being here that you spare the patient a stoma, and then in bilateral disease, you're still going to allow the bladder to cycle and to fill. Essentially, what you're doing here is saying that you're prepared to trade obstruction for reflux. So, you know, I think most of us would agree that obstruction is worse than reflux. It's a higher risk for infections and loss of renal units. With time, I think many of us are becoming less and less concerned with reflux. But what these guys do is essentially take the ureter and kind of plug it onto the dome or the anterior aspect of the bladder. This will be a reflexing reimplant. There's no tunnel. And it, kind of ties your baby over until once again you can do a formal reimplant. This is not intended to be definitive surgery. So in Indiana, when they do this procedure, they go back a year later and reimplant the patients. I just want to say, like, there is a nice video lecture of Martin Kiefer describing this procedure. And he is at pains to say that it's a very easy operation, but he really does recommend that you watch the video, which is available first before attempting the surgery, just because there are a couple of key points that you need to know about. Specifically, I think about kind of preserving the blood supply of the ureter and the resection of a bit of redundant ureter, which is sometimes done. So they feel that with their procedure, they have a really lower complication rate. They feel that, the infection rate is about 35%, which is probably equivalent to all children with a primary obstructed megaureter. So about a third of them will get an infection still, but they have really good outcomes with this, and they're very happy with this operation. And it's also a good option for children who have a single functional system, so an absent contralateral system. So to talk about a re-implant, which is once again the most conventional and definitive procedure. The objective of your surgery is to reduce the ureteric caliber, to reduce your reflux, but to allow emptying. You want to protect the ureteric blood supply and avoid damage to the bladder. Just a couple of technical notes. The tunnel length should be long enough to accommodate the diameter of the ureter. The hiatus of the ureter shouldn't be lateral, and you should try to avoid kinks and angulation. Just, things to think about when you're dealing with a mega ureter is that you can't just plug this giant ureter straight back into the bladder, and you need to taper it a bit. You need to excise this distal narrow segment. And then depending on the size of the ureter, you can try to just fold it or taper it like this, which theoretically helps to preserve a bit of blood supply. But there's this magic number of 1.75 centimeters. If it's wider than that, you actually need to consider resecting a bit of ureter, which can lead to blood supply issues. But yeah, your tunnel shouldn't really be long than your tapered or your resected section. And then once again, you kind of really want to do this in a bigger baby to reduce your risk of bladder damage and other complications. And then I'll just touch on the side-to-side Ureterostomy. So we did a lot of these in Toronto, and I have to say, once again, it's a very, very easy operation. And once again, it's also just a reflexing procedure where you, once again, obviating the obstruction, but you're allowing some reflux. And really, they do a small, tiny, like you can see here, this incision is maybe 2 or 3 centimeters in the right lower quadrant. It's usually ultrasound guided, so they fill up the bladder and then have a look at where they see the ureter and the bladder touching each other, do a little incision, and then really just do a little side-to-side anastomosis, leaving the native UO as is. So like I said, very simple operation. You can do it in very small babies. I think the average age of patients in this study was 3 months. Babies go home very quickly. They sometimes get UTIs, once again, as always, but some of them, this is intended as a definitive procedure. So the Toronto group has no intention of going back to do a reimplant in these kids. It allows reflux and the dilation goes away. But some of these babies do go on to require a definitive replant anyway, because they have recurrent infections from their reflux. And some of them actually also get stenosis of the anastomosis and get recurrent obstruction. So yeah, my final words in urology, there's never a single right answer. And I think it's always best to do what is safe and to do what you know, and to ask for help or advice when it is possible. I think, we always present all of these things as very easy options, but all of us who do these surgeries know that these patients do come back with complications. And I'm happy to take any questions.
Karen, thank you very much. It's quite a vast topic, and pediatric urology is all interconnected. Upper tract, lower tract, bladder, everything is interconnected. So you gave us a very nice wide overview of ureteric abnormalities. And I think your last slide is probably the most important, that you do what you think is safe. And also you highlighted that many of these dilated systems, they just recover with time. And that's quite an important message. And don't look at the dilatation, and think of operating, and also try and avoid it intravesical operations in young babies up to in the first year of life. So I think these are quite important messages. If I'll just ask Dr. Yashoda Manikchand, our consultant pediatric surgeon, to give comments, because in 5 minutes time, she's likely to have load shedding at her place. and may not be able to comment. So Yashoda.
Hi, thanks, Prof. Yes, definitely load shedding at 6 p.m. So thanks, Karen, for the talk. It was really good to get the overview and the different surgical options. We don't see a lot of primary megaureter, but what we do see is the Eagle Barrett's or the prune belly syndrome patients. I wanted to ask if there's any specific advice you would give for following those patients up, and when does it differ, the indications for surgery for them, because they progressively get dilated and obstructed.
Yeah. So they're a particularly difficult group of patients, also because there may be kind of in that fourth group of like non-refluxing, non-obstructing, and that their dilatation is often kind of related to their global kind of lack of abdominal musculature. I have to say, we tended towards the fairly conservative with them in Toronto. So kind of trying to ignore ureteric dilatation so much and rather focus on kind of upstream issues. So whether or not they were getting infections and then progressive hydro and parenchymal thinning. A couple of patients, they don't have valves, but they've got, kind of a lower, a urethral and sort of hypoplasia almost. And a couple of these patients do end up with vesicostomies, which doesn't always resolve the hydroureter. We were pretty reluctant to re-implant these guys too soon, and often sort of waited until they were really old. They really had to earn their ureteric surgery, because once again, they're kind of a type where the ureter is not always the primary problem. I don't know if that answers your question. They're a really difficult group of patients. And I think, you kind of take them on the case-by-case basis. But a subgroup of them do progress to renal failure. And you do kind of want to prevent that where you can.
Okay, thank you. We might call you about specific patients. Thanks.
I'm sure Karen would not mind me asking her advice for a specific patient. And Karen, what I also liked was to see that you advocated ureterostomy. I thought that operation had gone into disrepute, but because that's something which we had done in Mumbai long time ago when I was training. My consultants had done that operation, and it really tied over the crisis, and children's lives could be saved. And I think that is something important for young pediatric surgeons to know, that we are used to doing colostomy, so it is one can do a ureterostomy, and then you can decide to refer the patient to a more experienced and competent surgeon. So I like that you mentioned about ureterostomy as well.
It's sort of interesting for me, because I think most of us, consenting a parent for a colostomy is like second nature. We all know it's going to be okay. It's a temporary thing, but there's something that feels worse about telling a patient you're going to do a ureterostomy, and I think it's because we don't do them that often. But for me, it's also better than a device. So if I have a patient where I have a choice between doing a stoma or a situation where if I put in a nephrostomy tube, I know it's going to be there for a long time, I would really prefer to go for the stoma, because the nephrostomy tubes give a lot of problems. They block, they fall out. It's difficult for the parents to manage them. They get infected.
Yes,
and I have to say, even in Toronto, we did a fair number of ureterostomies for like a really very kind of patient group. So for lots of different indications, but it was definitely something that we still did.
Yeah, I think it is very important that you brought this point out, and that is an operation which a competent pediatric surgeon will be able to do, and will certainly be able to tide over the crisis. I see Prof. Cepularo joined a little bit later, but I'll ask him if he has any comments. Professor Cepularo, Neveleni? Is Professor Cepularo still here, or has he left? He's here. Neveleni, can you unmute yourself, please? I'm not sure whether he's able to hear me. I saw Dr. Matlaung was here. Iliot, struggling to unmute.
Yes, Prof.
Yes. Yes, Nalini, can you unmute yourself? In the meantime, Iliot, do you have any comment?
No, thank you very much, Prof. It was a good presentation. I've learned a lot. Thank you.
Okay. Prof. Sepularo says, enjoyed the presentation. Are you able to unmute yourself, Nalini? No, it looks like he's got there's problem to unmute. Karen, I will ask you to give like a final comment, take home message, and I thank you for your presentation.
I was going to ask, I saw Prof. Lazarus here earlier. I think maybe he's gone now. I was going to ask him if he had any comments. But yeah, I think we're always, we're a small community here, so we also are always happy to answer any questions or answer the phone. Yeah, we're always happy to be available and to give any kind of advice that we can.
Thank you, Karen. I think that's good to know. And I think this is the beautiful Nelson Mandela Children's Hospital. So those of us who haven't visited it, it's now fully functional. So when you are in Johannesburg next time, either talk to Dr. Karen Milford or Dr. Andrew Grieve, and they will be happy to show you around. And
yeah, we love to have visitors.
Yes.
Yeah, we really do. I'm always happy to have anybody who wants to come and say hi.
Yeah, we visited when it wasn't fully functional. I think only one ward was functioning, but it is nice to know that it is fully functional now. So Karen, thank you once again. And
thank you for having me.
Next presentation will be on the Tuesday, 7th of December. Dr. Ashwini Maharaj, consultant pediatric surgeon in Durban, he will give a talk about HIV and pediatric surgery. So that's going to be quite an interesting talk, and that will be the last talk for the year. So we will post the invitation for that meeting a week in advance. So thank you, everybody. I wish you well, and we see you in a month's time. Bye-bye.
Thanks. Bye.